Sujatra, and a very good day to everyone. My name is Dr. Lee Wan Ling, and I'm from the Department of Nursing Science, Faculty of Medicine, University Malaya. It's my utmost pleasure to moderate the first session of the talk entitled Cardiac Rehabilitation, Practice and Research Sharing. As we know, cardiac rehab is a Class 1A recommendation. It has been proven to significantly reduce secondary cardiovascular events and mortality. However, it remains an underutilized intervention. Today, we are privileged to have a prominent nurse scientist, Professor Ying Chia, all the way from Hong Kong to share her experience and rich insight on cardiac rehab, especially on how nurses navigate her roles and functions in a multidisciplinary cardiac rehab team and drive research in cardiac rehab. Ladies and gentlemen, Professor Chia is the Vice Director of Research and the Head of Graduate Divisions of the Nedeso School of Nursing, Faculty of Medicine, the Chinese University of Hong Kong. She is a Fellow of the prestigious American Academy of Nursing and the co-chair of the International Council of Nurses, ICN, Advanced Practice Nursing Network, APNN. She is also the president of the Hong Kong Academy of Nursing, the founding presidents and council members of the Hong Kong College of Cardiac Nursing. Professor Chia received her PhD in nursing from the University of Colorado Health Sciences Center, Denver, United States. Her research interests focus on cardiovascular and critical care nursing. She has published over 190 peer-reviewed journals papers and has been invited to deliver talks at many international conferences. She has attained over 30 competitive research grants. Last year, in 2022, she was awarded the Chief Executive Commendations for Community Service in recognition of her outstanding contributions to fight against COVID-19. Professor Chia is included in the list of the top 2% scientists of the world for the year 2021. With her impressive track record, we look forward to hearing Professor Chia sharing. But before that, just a note to the members of the audience. Please type your name, your affiliations, and your question on the Zoom chat function, and we will have a Q&A immediately after Professor Chia presentations. So without further ado, Professor Chia, the platform is yours.
Okay, thank you for your nice introduction. Let's try to get it started. Talking about cardiovascular disease, number one, leading cause of death worldwide, and more importantly to me is 3 out of the 4 deaths in the world from cardiovascular disease occur in low and middle income country. That means what? That means there's huge more work should be done in the lower and middle income country. Let's take a look at the Hong Kong situation. If you look at the 80s, 90s, we do have, pretty high cause of death from cardiovascular disease. And not until the year 2000 and onward, you can see there's a decreasing trend on CV disease mortality. And up till now, cardiovascular disease still the 3rd most common cause of death in Hong Kong and accounting for 13% of all death. And when I started doing research like about 20 years ago, it was accounting like 16% of total death. So we are doing better now. We are improving the situation, as you can tell from this picture. And cardiac rehab is an integrated treatment for individuals after cardiac event. Major components or core components of cardiac rehab, majority of them can be performed by nurses. Talking about the physical assessment, nutrition counseling, and this side of the work, dietitian will contribute to it. But dietitian usually will not see the patient every time when they come back to the hospital. Nurses will. So dietitian has certain contribution, but to follow up with patient's development, and nurses should be having a heavy role in here for nutrition counseling, weight control, blood pressure, lipid, diabetes management, and tobacco control, tobacco cessation. For psychosocial management, more likely we focus on stress management. And physio will do more on this part, like exercise training, physical activity counseling. So if you see this picture, you see nursing actually playing a very important role in the whole cardio rehab service. Talking about the benefit of cardio rehab, yeah, we all know that, it's always good for our patients. And then reducing the CV death, reducing the chance of developing, secondary, prevention, reducing the chance of, second cardiac heart attack, and reducing the risk of developing stroke and having better psychological health. Target patients for cardiac rehab, basically all disease and all cardiac related disease will be suitable, for those patients to join the rehab program. And in Hong Kong, more likely we have, PCI patients, cardiac myopathy. Some of the centers will take those kind of high risk patients, but not all of them. And then chest pain, stable angina, bypass patient, heart attack, and heart failure patient, so far and so on. Talking about the phases of cardiac rehab, and I like, and many of the centers here, we have phase 1, phase 2, phase 3. Some of the centers still classify to have 1, 2, 3, 4. And then I like this one better because it's more distinct and more clear cut, for the patients. Like the first phase will be inpatient. They were, still in the hospital. And then physio will have more contribution in this phase. And mostly in Hong Kong, the physiotherapist will walk patient, along the hallway and then going back to the bed for rest. And then the second phase is after patients being discharged from the hospital, and then they will go back to the center as a day case. And then they do exercise, after the thorough assessment. Exercise will be prescribed by a physio, and nurses will do education and then coach patient, with eating plan and so far, so on. And then all the education will be focusing on risk modification, the modifiable risk, and then psychosocial counseling to reduce stress. And then the last phase will be maintenance phase, and then this phase will be mostly conducted in the community. In Hong Kong, after the hospital rehab centers, patients can go to community networking centers. The history about cardiac rehab in Hong Kong, we started early. We started in the early 90s. And then at that time, only pilot program developed here and there in individual hospitals. Not until the formal training, the structure education program was developed in the 94 and 96. And then we have more number of nurses being prepared to operate the cardiac rehab center. Then till 1997, we have 13 hospitals. They are offering cardiac rehab program. They have the cardiac rehab team. So even though, like in Hong Kong, majority of the hospital, we're talking about 78% of the hospital will be operated under Hospital Authority Hong Kong. That's government funded programs. And then for all the hospital in Hong Kong, under the Hospital Authority, their program may not be necessary. They're similar, but not necessary to be the same. So I just picked 2 examples to share with you. This one, is operated in Princess Margaret Hospital. They have the phase 1 inpatient rehab and phase 2 outpatient phase. Patient returning to the center for that. And then 3 and 4 will be on the, the cardiac rehab will be conducted in the community organizations. And hopefully, we give patient enough time to build up their exercise habit, build up their lifestyle modification habits. And then in 2007, the Community Rehabilitation Network was invited to set up a similar cardiac rehab program near the hospital in the, near the PMH hospital to offer cardiac rehabilitation. And then from 2010 onward, the Community Cardiac Rehab Program Phase 2 was implemented formally. And then we'll talk later. I'll talk a little bit about the PMH, how they do it. And then I will talk more on the Donghua Eastern Hospital, because that is my research site. And then they have very good comprehensive cardiac rehab program there. And then in Hong Kong, we divided into 7 clusters. Hong Kong, Donghua Eastern Hospital, located at Hong Kong East Cluster at the Hong Kong Island, the east part of Hong Kong Island. And then the team, including the rehab physician, the CR nurses, physio, ocul, and dietitian. And then they have a longer period of center-based cardiac rehab. They have 8 weeks, 3 sections per week. So a total of 24 supervised exercise sections. So it's a little bit longer than the others. So they grouping like phase 2 and phase 3 together. And then they also offer 6 group educational sections for the participants. And the education focus will be on diet, exercise, smoking cessation, stress management, drug compliance, heart disease related knowledge. And then they will have, all participants will have 1 hour individual dietitian consultation section to be offered. And the dietitian will work out like a 7-day diet plan for each individual patient, teach them about the food exchange, the better choice of food, and also barriers if they eat out frequently for those workers for diet. And then they have a 3-month follow-up, or finish 8 weeks, and then 3 months they are returning for follow-up. And some of them, they do the further follow-up until 6 months, but majority of them will be 3 months. And this study, we collected the data. It was a long time ago when I started to do my work there. So we just collected information, and then as you can see, baseline 8 weeks after they finished the program and 3-month follow-up, exercise intensity has significantly improved. And then the HDL also has significant improvement by statistically view. And if you look at the number, the mean value number, baseline compared to 8 weeks, all numbers has been improved. But when it goes to 3 months, not that many, no further improvement, but some of the numbers start to deteriorate. So this is the phenomenon that we see after patients leave the program. And many of them, they start, gradually going back to the sedative diet and sedative living style. The cardiac rehab program in Princess Margaret Hospital, the assessment will be done by the cardiac nurse first, and then depends on the condition of the patients, they will be allocated either in PMH or in the CRN. These will be the inclusion criteria. More stabilized patient will be going to the CRN. And then the social worker in CRN will contact the patient first, and then patient will have to do the registration. They will ask the patient whether they would like to join the CRN voluntary or not, because the charge in CRN will be more expensive than the hospital. So, and especially patients joining the hospital programs under hospital authority, those majority of them, they are, not very rich. And then, so patient will have to pay this, not expensive, but $100-something, Hong Kong dollars. So will be like maybe like 70 Malaysian dollar. And then the physio will do, follow up with their backgrounds and informations and do the thorough assessment on those patients, and then starting having the exercise over there, for 6 weeks and 2.5 hours per week. And the education and supervised exercise will be done in the community center and community rehab network. So talking about majority of the hospital under hospital authority, they will have a cardiac rehab center to be offered. And then to further follow up with the patients in here, mostly will be done in the community. And nurses in the cardiac rehab center playing a very important role, because, majority of the work will be performed by nurses, in education, in coordination. And then patients will have a chance to see dietitian, to work with the physio, and the physiotherapist will mainly focusing on exercise, developing the schedule for the patient, design what type of exercise, the intensity of exercise for the patient. And not only going to the center, when patients go home, they supposed, to perform their exercise by themselves. There's a chat. Okay, to fill up the form. Okay. Now, let's talk a little bit about the studies, what nurses can do in cardiac rehab. And I name out a few, home-based cardiac rehab, motivational interview, and e-approach of it. So for the home base, this study was conducted a long time ago by one of my PhD students. At that time, China did not have the cardiac rehab program. So it will be difficult for her to change the normal practice because of the resources constraint. So what she did is to develop some kind of booklet, written material, to help the patient to perform home-based rehabilitation, do the cardiac rehab at home, following the book, the guideline that she said it in the book. Is a randomized control trial targeting, recruiting them post-MI patients, and 80 participants in the intervention group. And the intervention group, on top of the usual care, usual care is when patient discharged, they would get verbal instructions and follow-ups on medication and so far and so on. And then there's 6 weeks program. And then the home-based rehab program is a self-help manual. That means the participants will have to read the information themselves. And there is 1 hour introductory section. That means before the patient going home, my PhD student had a one-to-one section with them, to talk about how to use the booklet and how to perform the exercise, and then addressing questions when the participants have. And then divided into 3 sections. The first section in the booklet is CV, disease process, risk factors, healthy life style, and stress management, and home exercise and relaxation plans. And the second section is talking about the medication, the effect, the side effect, what to look for, and the importance of medication compliance, and then what are the procedures they receive and the consequence after MI. And the last section is on the, normal range parameters of the lab work, and then food values, and then, the food exchange in the last section. And control group, just, normal, usual practice. And then they measure the health-related quality of life, anxiety, and depression. In this study, data collected at baseline 6 weeks, 3 months, and 6 months. And then not very effective, but we do see significant improvement in anxiety level and health-related quality of life. And we have a lot of limitations in this study, because participants will have to have, at least a junior high education. Otherwise, they won't be able to read those materials. And then it will be difficult, like whether the patient reading the material or not, because they would do everything by themselves at home. So, and I think this might contribute to the results. And then The second one I would like to talk about is the motivational interview. And this study was done, longer than 10 years ago. And then when we designed this study, motivational interview in Hong Kong was like pretty much like the golden remedy for everything. And people use motivational interview for DM patient on diet control, motivational interviewing used on gambling patient, on drug abuse patient, and it seems very effective on those patients. So we try motivational interview on cardiac rehab patient, poor motivated cardiac rehab patient, and see what the result will be. And then we look at the short-term and long-term effect of motivational interview on clinical outcomes, psychological outcomes, and quality of life on cardiac rehab patients with poor motivation. Okay, because we have to define poor motivation, so we use the readiness to change score less than 10 to classify as poorly motivated. So 73 for each group, and then inclusion exclusion criteria. And then for the 6-month program, the week 1 to week 8, we offered 2 sections per week, 16 supervised exercise section, and then health education, like 1 section per week, and meeting the dietitian ones. And then for the follow-up 3 to 6 months, they only returning to the center for 1 section per week. And then 9 to 12 months, no extra interventions will be offered, but just returning to collect the data. And talking about the motivational interview, that, the usual group will do that. And then on top of it, every other week, the intervention group will receive 1 section of motivational interviewing section. And the content will be, working with them to identify the need for lifestyle changes, assessing the feelings and things like that. Just follow motivational interviews recommendation to do that. In a total of 7 motivational interview section will be offered to the experimental group or the intervention group. Just show you, the baseline characteristic. There's no difference between the two groups. That means patients in the control group and experimental group are pretty much the same. When we look at the short-term effect, we don't see much of the difference between the 2 groups. Only here and there, like the anxiety scale, we do see difference. And but when we look at it as the 3 month, when we look at it, the baseline for the control group actually is improving. For the experimental group is a little bit increased. And then the subscales of SF36 has some improvement. So when we look at the long-term effect on motivational interview, again, the subscales of SF36 has certain improvement. Others, physiological clinical outcomes, physiological outcomes has no difference between the 2 groups. So we spend so much money, so much time to look at it. So we would like to know why, the result is not significant. Actually, the center that I picked is a very, very comprehensive cardiac rehab program offered in that center. So the control group also has improvement. Compared to the control group, pretty much like a ceiling effect. If the control group improves so much, and then on top of it, you want to further improve, you have to put in extra efforts to get a little bit of improvement. This is the case that we have. So after this, because MI was so much being talked about it in healthcare at that time, so we make a recommendation to the government to run or to operate a very nice or comprehensive, good quality cardiac rehab program will be good enough rather than adding extra element into it. So this pretty much what we recommend. And here I would like to show you about, you probably like, you guys know Joanne Maxim, right? She's from your university, and she is studying a PhD here. And she is using a technology-assisted cardiac rehab program. Before she conduct hers, she will have to understand the situation, like which type of technology or which component of the technology works better. And then our duration of the cardiac rehab program works better. What will be the common study outcomes being picked by the others to justify her program? So she did a systematic review and meta-analysis, which has been published in IJNS. IJNS has, which is the highest impact factor journal in nursing. And then and she has the meta-analysis published there. And then to inform from her systematic review, she developed a theory-based program. And this is the feasibility program. That is, she only published her pilot work. She did a pilot study before the main study, so she published her work here. So if you are interested, you can take a look. And then, and another way of doing it, the web-based education program, one of my colleagues working with me, this study also, we have this study decided more than 10 years ago, but with the delay of data collection during COVID, and then we get it out kind of late. And then we use a web-based, we develop, we have face-to-face section, and then, the patients will go to the web base. We give the link to each patient, and you have to type in your password. We give they create their own password. They have educational material there, and individual member area that you have to record, your blood pressure, your exercise details, and your diet details. And then in that page, and then the researcher can access to all the pages, and then to make the comparison. And total amount of physical exercise and HDL has been improved, not other factors being improved. And then from here, that it's so difficult to change people's behavior, and it's so difficult to get a very positive result on everything. So sometimes when I read some of the studies, especially, and I shouldn't name the country, but especially when you read some of the results, everything is so significant. I've been conducting this kind of study for like 20-something years, and you only have part of your outcomes being significantly improved. But, seldom do you have all of them to be significantly improved. And then here, I would like to share another study with you. This study, the student is from Macau, and she got a funding to build up a mobile app for cardiac rehab. And then also cardiac rehab was not, widely implemented in Macau. So in order to change the hospital practice, it would be difficult. So she developed the app to help for that. And then also a randomized control trial. The reason we always run randomized control trial, because we want evenly distributing the confounding variables between the two groups at the same time. We have a very good randomization, so we try to eliminate the selection bias. And then 70 participants in each group, and she developed a mobile health cardiac rehabilitation application. It has education section, recording section, result section, and Q&A. The beauty of it is, she has a group of, she's a departmental operation manager. She has, a couple departments under her. So she has her colleagues to help her to addressing questions being posted there. And then, she looked at a bunch of the outcomes: medication compliance, healthcare utilization, functional activity, risk factors, and self-efficacy. And then she has some of her results are pretty good. Total cholesterol level, LDL, sitting time reduced, anxiety reduced, total anxiety and depression level, 6 minutes walk increased, regular exercise performance, self-efficacy on diet and exercise, 2 instruments, and quality of life have been improved. And the satisfaction level from the one who used the app, receiving 91% of satisfaction. So this is another way of doing it in eBase, especially during the COVID period, it will be difficult for patient to return to the hospital, and nobody wants to go to the hospital unless it is necessary. So approach will be beneficial to those patients. Okay. All right. Hit my time. And then
Yes.
Wan Ning, I know you have two questions. Can you raise your question here?
Okay, thank you very much, Prof. Chair, for the enlightening sharing of the cardiac rehab programs and the research done in Hong Kong. But unfortunately, in the interest of time, we will have to move on to the next sessions.
Okay.
And to the audience who would like to find out more, you can always email to Prof. Chair. I think you can find her from the website.
One more thing. I would like to promote the PhD program here. The scholarship here is kind of huge. If you got the best scholarship is like $3,000 a month. And then the regular one is $2,200 a month to study here. So we give you enough money to survive and to get rich. Okay, by studying here. And we make sure you got like at least 3 publications before you leave the program. So, all right. Thank you. Email me if you need further explanation. Thank you.
Okay. Before we move to the next section, on behalf of the Department of Nursing Science, I would like to express our gratitude and appreciation to Professor Chair for her time and her invaluable sharing on cardiac rehab. Thank you very much, Prof. So now I hand over the platform to Associate Professor Dr. Loh Pui San, Head of Department of Anesthesiology. So over to you, Prof. Loh.
Thank you very much.